My name is Dr. Scott Berman. I'm the psychiatrist at Holcomb Behavioral Health Systems in Allentown and Easton, Pennsylvania. I'll be talking to you about our program called Graduate, or Gradual Reduction of Anxiety Drugs using alternative techniques. We'll be talking about this because many of our patients, many psychiatric patients at many centers, end up on chronic doses daily of benzodiazepines when they probably don't need to be at such a high dose, or probably don't even need to take them every day. We certainly all use a lot of pills in our society, as well as candy and other things to comfort ourselves in a time of very high stress. But it's not clear they do all that much for us. The most common anxiety pill is benzodiazepines, or benzos, that include Valium, or diazepam, Klonopin, or clonazepam, Xanax, or alprazolam, Ativan, or lorazepam, Restoril, or temazepam, Librium, or chlordiazepoxide, and also not listed here, Cerax, or oxazepam. They have different potencies or strengths, such that 10 milligrams of Valium can be approximated with only 2 milligrams of Ativan, or 1 of Xanax, or 0.5 of Klonopin. So somebody taking 1 milligram of Xanax 3 times a day, or 3 milligrams of Xanax, is really taking about 30 of Valium. This is important because we use Valium equivalents when we talk about withdrawing or detoxing people. We do this because Valium is long-acting and it makes withdrawal and tapering much easier than some of the short-acting ones like Xanax or Ativan. Benzodiazepines have benefits such as working fast, being reliable in the short term, and few risky side effects in the short term. There are some patients who do benefit long term and for whom other medications tend not to work quite as well. But this is still a minority of patients, and many people are over-medicated on benzodiazepines. They can cause dependency. They reduce the ability to learn to manage anxiety. Cognitive behavioral therapists don't like them because when you take them, you don't learn to handle the situation yourself, and you think it was the benzo that got you through. It can cause sedation, falls, memory impairment, and more motor vehicle accidents. And in fact, we still worry in the therapy sense that as long as you stay on benzos, you may never learn how to manage your anxiety on your own. And anxiety can be managed without medication. And in fact, we often see that our patients on benzos, when given anxiety rating scales, still score very high. And the question is, you're taking your benzo every day, sometimes at high doses, but you're still telling us your anxiety is chronic, severe, sometimes unmanageable. So what are you getting out of the benzo at that point? There's a 5 times higher risk of memory and concentration problems for people who take benzos, a 4-time increased risk of daytime fatigue, a doubling the risk for falls and fractures, a double the risk for having a motor vehicle accident. Benzos are safe when used alone, but they have dangerous interactions with other drugs. The interaction of benzos and opiates or narcotics, painkillers, or with alcohol can be coma and even fatalities. And in fact, in some studies, most of the fatalities from opiates or benzos come when they are mixed, and they commonly are mixed for a number of patients. They also can interact with other medicines, and there's other medicines that we commonly use in psychiatry that can dramatically increase the benzo level, which can again be dangerous. There are good alternative anxiety medications. They don't work fast in a half an hour or an hour, but after several weeks of being on them, Prozac, Paxil, Zoloft, Lexapro, Celexa, Effexor, Pristiq, Cymbalta, Fezima all have the ability to dramatically reduce both generalized anxiety, social phobia, panic attacks. To some extent, they work for PTSD, and some of them work for OCD. We could also use Buspar, which works only for generalized anxiety, not for panic attacks. 2 of our medicines that we use for neuropathic pain, Neurontin and Lyrica, are also quite good for anxiety. Atarax is a weak but useful medicine because we can take it as needed. Seroquel, which is antipsychotic and bipolar medicine, is quite good for anxiety. Remeron, Vibrid work to some extent. And interestingly, Nardil, a very old medication, can be very effective for panic attacks and social phobia that don't remit with anything else. And Nafranil, clomipramine can be very useful for severe OCD and panic attacks. So we certainly have alternatives. We have to explain to our patients that these are medicines that work quite well, possibly better than benzos, but they take longer to work. So it's not uncommon to start somebody on a primary anti-anxiety medicine like Prozac or Zoloft, or for that matter, Lyrica or Anafranil, and start with a little bit of Klonopin or Ativan at the time, and hope to taper that once the long-acting medicine is in place and protecting from future panic or anxiety attacks. So this slide is a joke about how often we depend on our doctors to give us medicine for uncomfortable symptoms. Benzos reinforce our belief that we can't handle stressful situations. Thus, they make us anxious, thinking that we can't handle things on our own, and they increase both our dependency and future anxiety. We talk about behavioral therapy. In the next part, you'll see how much benzos reduce our ability to get us out of the cycle of anxiety. And again, we see this all the time. And the patient's saying, maybe I need to change my life, or maybe you could just tweak my meds. And we see people who have not really been exposed to good quality therapy or CBT, cognitive behavioral techniques, and they just want to change the meds, but have lost the incentive to work on resolving the anxiety. Anxiety has 4 cardinal symptoms. A for affect or feelings, B for behavior, C for cognition or thoughts, and S for physical symptoms. So the feelings are anxiousness, dread, fear, and panic. The thoughts are that something horrible is going to happen. The behaviors are avoidance, self-medication, fleeing, checking, reassuring. And the symptoms are rapid heartbeat, chest tightness, shortness of breath, sweats, nausea, blushing, and others. What leads to an anxiety attack? Well, there has to be a perceived threat and cognitive distortions. What do we mean by that? It may not be something that everybody would be threatened by, but some people have a perception that there's a threat getting on an elevator or getting on a plane or going to a party. And the threat comes about because there's cognitive distortions, kind of an automatic, oh my God, this is going to be risky for me. Something's going to happen that's not very good. And along with this, for anxious people, comes elevated anxiety sensitivity. Anxious people respond much more quickly to their own internal stimuli, that is, feeling their heartbeat a little fast, a little shortness of breath, a little stomach discomfort. This ratchets them up very quickly compared to non-anxious people. So if they see the perceived threat, believe distorted, catastrophic things about something that's probably not risky, and feel their internal anxiety symptoms coming up, they become very anxious. The perceived threat in a panic disorder is your own internal sensations. You feel the fast heartbeat, the shortness of breath, and you think, my God, I'm having a heart attack. Social anxiety, the threat is social situations. In generalized anxiety, it's essentially everything. You look at the pile of work on your desk and say, oh my God, I'm going to fall behind, they're going to fire me. You go to school, you take a test, oh my God, I'm going to fail that. Everything becomes a chore and difficult and insurmountable. PTSD triggers are based on the kind of trauma you've been through. It's post-traumatic stress disorder. What kind of distortions? In panic attack disorder, it's I'm having a heart attack, I'm sick, I'm going crazy. In social anxiety, people are laughing at me, I'm embarrassing myself. Generalized anxiety, I'll make a mistake, I'll mess things up, I'll lose my job, I'll flunk out of school. PTSD has to do with feeling the world's not safe anymore, or that you're not safe. And increased anxiety sensitivity, we touched on that small things like rapid heartbeat, people looking at you, trigger a much higher level of anxiety, leading to the anxiety attacks. And the attacks themselves are not the anticipatory mild dread or anxiety, it's a full-blown attack, such that panic attack patients get racing heart, shortness of breath, chest tightness, nausea, sweats, along with the feeling of pending doom that this is the worst ever. Social anxiety patients sweat, tremor, blush. Generalized anxiety disorder patients are tense, they're headachy, restless, insomnia. Post-traumatic stress disorder patients are a mix, but emotional symptoms such as fear and dread, and physical symptoms such as racing heartbeat and shortness of breath. After the attack, 2 critical things happen that fuel future attacks. One is anticipatory anxiety, fear of fear, worry about the next attack or the next trigger. The other is avoidance. And avoidance really is the main thing that, for a lot of people, continues to keep them anxious. The more they avoid, the more they fantasize about how horrible their trigger is and how they could never handle it. And we all do things called false safety behaviors. We do things to protect us. So a reasonable safety behavior is putting on your seatbelt or stopping at a red light. False safety behaviors are things we do with a kind of 4-leaf clover or rubbing a lucky rabbit's foot belief that it will keep us safe. They fall into 5 kinds: avoidance, checking, mentally distracting ourselves, safety aids, and reassurance. Let's talk about what these mean. Avoidance is avoiding the people, places, and things that trigger anxiety: heights, places, planes, closed places, crowds. Avoiding bodily sensations. A panic patient who won't exercise, they won't feel their heartbeat fast. Somebody who avoids alcohol because they don't want to feel out of control, or somebody who avoids a warm pool because they don't want to feel too hot or dizzy. And avoiding memories and feelings that might trigger us. And if the avoidance in the end doesn't help us, it makes us more fearful and then more avoidant. Checking our pulse or blood pressure, Googling symptoms, checking the locks, the doors, triple checking our homework, quadruple checking an email to make sure we didn't say the wrong thing. All make us more anxious, so they're false safety behaviors. They don't help. Mental distraction, watching TV, listening to music, not for relaxation, but basically to shut our brains up and avoid thinking about the thing we're worried about. Safety aids, carrying pills, bringing somebody for reassurance, taking an as-needed benzo, the ultimate safety aid. Reassurance, asking people, am I okay? Doc, am I okay? Asking your wife, you still love me? All adds up to nothing because it lasts for a second or two and then you're just as nervous the next time. So these don't help you feel better. If they did, we wouldn't have this conversation. They fail to work because they provide a temporary tiny drop in anxiety, but they reinforce your belief that you're in danger or incapable of handling things, which makes you more anxious the next time you have to handle the same situation. Why do they fail? Well, misattribution. We get through a feared situation using a safety behavior. We misattribute or believe the safety behavior is why we got through. I only passed the test because I worried so much. I only made it through the fight because I had 2 drinks. I only didn't have a panic attack because I took my Xanax. As long as you're using these magic beans, you never believe you could have done it yourself, so you never gain confidence and lose the anxiety. And in fact, you feel weaker and more terrified. And if you show up at the plane or the party without your Xanax, you're increasingly unbelieving that you could have handled it on your own. And avoidance blocks threat disconfirmation. Threat disconfirmation is when, for example, a little kid goes up to Santa, is nervous or hesitant, climbs on Santa's lap, and immediately realizes there's no real danger. It disconfirms the initial threat. But if the kid clings to mom's leg and runs away, surprised, next year they'll be just as scared, if not more scared, of Santa. They haven't learned anything. And safety aids, reassurance, and checking fail us as safety behaviors because we don't avoid the threat. We don't process it either. So, for instance, you take a Xanax, you get on a plane, say the rosary, check the wing to make sure it's not on fire, ask the flight attendant if everything is okay when there's turbulence. You haven't processed it. You don't notice that everybody else is sleeping or on their iPads or talking to each other. You get no positive cues about the safety of the situation, so you don't learn anything. And you're just as scared the next time you do this. That's the reason our safety behaviors do nothing for us. We can get addicted to safety behaviors. So a positive reinforcement is giving a dog a treat every time it does something you want. A negative reinforcement is taking away a negative. And why is this important? Well, when you avoid something, you call in sick to work because you're scared, you text your friend that you're skipping the party, your anxiety drops a few points. You've taken away a negative, you've taken away your anxiety. So then you want more of that, and you expect it. And you keep avoiding and avoiding again, but your fear goes up as your avoidance goes up, because you believe that the situation is so catastrophic you could never face it. Reducing or stopping benzos. Never stop suddenly. It can be dangerous, even fatal. Slowly reduce under medical supervision and weekly practice the alternative skills. So let's talk about our alternative skills. Relaxation. This will not make your panic attacks go away. And in fact, there's some studies that say you could do all the other parts of the treatment plan without relaxation and get the same result. However, most people with anxiety attacks, social phobia, generalized anxiety, have a chronic low-grade anxiety that's with them all day long. They don't know what it feels like to be relaxed. So it's a major benefit to learn a skill to get your anxiety way down, even to 0 on demand. Because then you know you can look forward to it. You feel that you've mastered something. There's some relief. And for this to work, whatever you pick with your therapist and work on, you've got to do every day. You can't do it just when you're anxious or it won't work. You've got to learn the skills so you can bring yourself down from more and more anxiety. And it's a great benefit because your baseline will be lower. You'll be more able to process things with lower baseline anxiety in therapy and with people on a day-to-day basis. but it's not the ultimate solution for very severe anxiety. It's just part of the puzzle. Cognitive reframing. What does that mean? People have always talked about cognitive therapy. People who are anxious do two things. They overestimate probability and cost. What does that mean? When we consider a risk, we consider probability. How likely is it that this will happen, and the cost? How bad is it if it happens? So for instance, we discussed medication side effects. A 50% probability of a minor cost, such as dry mouth, might be very acceptable. A 5% probability of a horrible side effect, such as death, might not be acceptable. You're multiplying the probability it will happen times what it is. What's the worst that would happen? People who are anxious overestimate both. An anxious student at the end of a semester will come in and say, 80% chance I'll fail my final, and then if I do, what? Well, they will flunk me out of school. I'll never get a degree. A non-anxious student will say, well, I've got a 10 to 20% chance of failing the final. If I don't make it this time and I do fail, I'll take the course again. Much more realistic, much less anxious. So when you tell yourself there's a high probability of something bad happening and the cost is very catastrophic, of course you get anxious. That's not crazy, that's reasonable. The mistake is in the initial data. Your probability and cost estimates are wrong, and you fed that to your brain, which now becomes terrified for no particular reason. Stopping false safety behaviors. We need to identify them, and we'll run a list with you and help you identify your own. We need to do it so that you can process an event without the false safety behaviors. As long as you used your crutch behavior at the time, you will never believe you could do it on your own, so you won't gain any confidence. Again, no learning, no anxiety reduction. Interoceptive exposure, fancy word for starting and stopping the uncomfortable physical feelings until you learn that they're controllable and that they don't equal a catastrophe. So particularly for panic attack patients, if we get them to hyperventilate, to simulate shortness of breath, or spin in a chair so they get dizzy, or run stairs, or run in place till they get high heart rate and sweating, and they calm down, they can start realizing that for an anxious person, physical symptoms may just be caused by anxiety through the body's fight or flight system and do not equal a heart attack, a stroke, or some horrible outcome. Doing this over and over can reduce the anxiety sensitivity or catastrophizing that anxious people get when they get a symptom. And if you like, you can copy and paste or find the YouTube video for exposure and see how this is done. Quite simple. Real life exposure. So we'll have you list the situations or things you're afraid of that cause you anxiety. Rank them from 0, none, to 100, maximal anxiety. Rewrite the list from the lowest to the highest. Then we'll work on homework going from easy to harder situations without safety behaviors and processing them so you gain confidence. If you think about this, this is really no different than learning to play the piano, starting with easy exercises and going to hard ones, being coached in a sport or anything else. It's all about learning, but in this case relearning, so we're dropping some of the distortions, anticipatory anxiety, and other things that have gotten in the way so you can master situations that other people have already mastered. To do the reduction, I will meet with you and set up a personal schedule. We'll monitor your vital signs, symptoms, and anxiety levels. All of our patients on controlled drugs already know that we monitor the state PDMP, prescription drug monitoring program, which is required of us to make sure your meds only come from us. And then we can ask for drug screens on demand to help maintain patient safety. For some of you, we'll reduce your daily dose. Others will use less than daily at the end goal. And some people might be able to stop using altogether. Though initially, dose reduction and less than daily, which means less dependency, will be the initial goals. Benzo reduction. Along with this in therapy, you'll choose and practice relaxation skills. Identify your cognitive distortions and work to correct them. Identify your personal false safety behaviors and work to reduce them. Interoceptive exposure to reduce your response to physical symptoms. In vivo exposure to practice handling real-life triggers. Processing with your therapist. And very important, self-monitoring with logs and rating scales we will provide for you. Self-monitoring is very important because adherence, following through, practice is how this stuff works. There is no magic, as there's no magic to becoming a virtuoso pianist or a great athlete. But with practice, you will maintain some gains. Some examples. So for panic attack sufferer, we have Jane, the panic attack sufferer. We have her doing progressive muscle relaxation using an app on her phone 15 minutes twice a day to get her baseline anxiety down. She's calmer in therapy. She can do more reframing. What's the real likelihood you're having a panic attack if you're a 30-year-old woman with no heart disease and no risk factors? The interoceptive exposures running in place and hyperventilating with a therapist. We start to reduce the false safety behaviors. No checking your pulse. No taking the Xanax when you get short of breath. Reduce your calls to your doctor. Stop going to the emergency room. And in vivo exposure, going to the gym, sitting in a crowded classroom, and processing it so you get better and better at it. How about Joe with social anxiety disorder? He goes to the gym a few times a week, which is great for reducing both your baseline anxiety as well as resting heart rate and your physical response to anxiety. The cognitive reframing. Are people really looking at you? What's the worst thing that would happen if people did laugh at you? What's the worst thing that would happen from embarrassment? False safety behaviors. No taking a Klonopin before class. No sitting in the back row anymore. Exposure. Sitting in the front, giving a talk. Again, gradual with help, so it's not suddenly being thrown in, but gradually acquiring skills. How about Susan with generalized anxiety disorder? Meditation, half an hour a day. Reframing. What happens if you make a mistake? What's the worst that could happen? Maybe spinning in a chair if she tends to hyperventilate and get dizzy. Stop rechecking your work. Stop staying late to make sure it's fine. Don't ask your boss every day if you did well. And you don't need a Valium every morning before work. And the in vivo exposure is both in real life, getting through the day on time, stopping the checking, and it can be imaginal, just imagining the assignment without distracting yourself, without catastrophizing until you realize that the risks are much lower than you think. How about somebody with PTSD? Mindfulness meditation with a mindfulness group once a week. Cognitive reframing. You were beaten as a kid, but it will happen as an adult. Exposure, hyperventilation to stimulate and control the shortness of breath. False safety behavior is often avoidance, and the exposure is starting to be with people more and more. So the long-term goals again. Not only lower doses alone are not a good outcome, but lower doses with lower anxiety, lower side effects, better self-confidence, increased ability to handle future stress, and overall better well-being. The psychiatrist says here, eventually I'd like to see you be able to put yourself back together. Thank you very much.